Okay. Well, thanks everybody for joining us for the final webinar of this year's ASSFN mentorship class. I'm really lucky that we're here tonight because our speakers are some of my closest friends and colleagues in neurosurgery that I've had many opportunities to work with. Dr. Sani was chief resident at Rush when I was Roy Bakay's fellow, and he was a great chief resident and took so much pressure off me as fellow. It was awesome, and I try to pay that forward with all my fellows moving forward.
I'd like to, before we get started, just a little bit housekeeping. I'd like to ask everyone to keep themselves if they haven't already, just so we don't have a lot of background noise. My name is Miriam Rahman. I'm at the University of...
Oh. Do you guys hear that anymore?
I think, yeah, no.
That was a Zoom bomb.
Okay. Okay. So with no further ado, Dr. Sani.
Thank you. Thanks, Julie. It's great to see you and everybody else. Without further ado, I'll start. I'm going to talk to you guys about growing your DBS business, which is an entirely different hat that you wear probably the other 95% of the time as a practicing neurologist or neurosurgeon. Next slide, please. My disclosures, I receive fellowship funding from these companies that help me train fellows. Other than that, I don't have any disclosures. Next slide, please. All right, so big picture, the general considerations, if you are just starting your DBS practice or you've been doing it for a while but looking to expand it, are based on these factors, right? At least this is what I've learned to be the main factors to consider in order to not only grow, but to have a sustainable referral source and a practice and a program that kind of keeps giving. And they include the following, and we'll discuss them in detail. First, you need to take a very good look at what kind of practice you're getting into or you're involved in. Obviously, the settings that we all know include private setting, a fully academic setting, and then sort of a blend, a private-demic, whereby you're working in a hospital that has either an affiliation or is somewhat associated with an academic institution. Another very important factor is the geographical location of your practice. Are you in a small town, big city? Are you an only institution that can provide your particular service, or are you one of many? Then it takes a while, but it is important to sit there and systematically identify all your possible referral sources. So we'll talk about that as well. And then the next step, which is where I personally have dropped the ball time and time again, and then I've learned that this is kind of like where things become frustrating, is how do you solidify referral sources? So as you start to build your program and hope to get more referrals and identify some referral sources, how do you build those relationships so that they continue to flourish without you having to put in as much extensive and intensive time as you did at the very beginning? We'll discuss some of the available resources to help you along with this, and I'll share some of the basic pearls of this. Next slide, please. All right, so practice settings and resources. Obviously, if you're in a private practice, it's sort of, I guess, referred to as kill what you eat. There are different models of this, but in essence, if you're looking to grow or start a DBS practice, you're pretty much responsible for identifying and building the entire team. Everything is your responsibility. There's no building block, and there's very little institutional help or resource available to you. So you're going to have to kind of gather all the team members yourself, and some of the costs of doing the marketing and building are going to come out of your own pocket or the practice pocket, if you will. You may be able to partner with one of the local hospitals. Obviously, if you have privileges, you can ask them to share the cost with you, because they'll benefit from the growth of your practice and additional surgeries that will come about. So that's another possibility. If you're working in a community hospital as an employee or with an affiliation, then you do have the option of tapping into the resources. So every hospital has a marketing department, which in my humble opinion is a double-edged sword, because they have a lot of restrictions, but they can be very helpful in terms of taking some of the work off your shoulders and kind of helping get the message out. And then they also have various clinical support. So in other words, you have other people that can help you do the stuff that you would do on your own. Now, there are restrictions because if you're working in a hospital, you have to abide by their interests and sort of some of their rules that they have. If you're in a private demic, you kind of have the best of both worlds, but you can also have the limitations that you don't have both of both worlds. So you can have some of the academic support, which brings you prestige and also resources that can take some loads off your shoulder by way of administrations and clinicians. But at the same time, if you're in an academic program, you're kind of locked into the mission and the pathway of that academic center. A full academic center employment, which I suspect will be the majority of people who are looking to start a good DBS practice, is sort of an organism of its own. Certainly, the business aspect applies, and you do have to find ways to grow your practice, but it's sort of from an inside-out perspective. You want to start growing it within the institution and then grow it on the outside. So it's very, very important that you identify the key players within the institution very early on. Who are your alliances? Who are the individuals who also have an interest in seeing you grow your DBS practice and who want to work with you and have common interests? And then there may be barriers. There may be neurologists, for example, who are very interested in medical therapy, non-surgical clinical trials. So they have a vested interest as a conflict with yours. And there are many ways to bridge that gap and build those bridges. And so it's essential to identify them so that you know what the next step is going to be. You also want to know, where is your chairman's goal? Is your chairman supportive of growing a DBS practice? And how do they see you growing it? Administration. So these are all very important bits of information, because you don't want to get too heavy and too far into one aspect of trying to grow your practice, only to realize that the key players are not on the same page as yours. Next slide, please. All right, geographical location. So where is your practice and what is your catchment area? Are you in a small town whereby you're sort of like the big fish and the major center, so that pretty much anybody who could potentially want DBS is going to have to come to you because there is very little else around you? Well, that's a whole different way of building a practice, because then all you have to do is, not all, but what you have to do is identify those patients, but you're not really competing. Or are you in a city like mine where there are at least 5 academic medical centers plus a number of private hospitals, all of whom have DBS programs of different sorts, and you already know that there are different specific referral patterns, and you're not as big of a fish, you're just one of the several, and therefore your mission is different. You have to find out how to identify yourself and what is unique about your program in order to attract those referrals. So, which brings us to the next point. You have to also identify the referral patterns wherever you are or wherever you're going, by way of knowing what are low-hanging fruit and what are difficult patterns to attain. For example, if there is a major health system in your catchment area, but they specifically refer all neurosurgical referrals to another major hospital other than yours for insurance reasons, you're going to have a very hard time obtaining patients from that, and that's going to be a very much more difficult task than looking after referrals that are open to going to whatever major hospital and they're looking for the best. That's where you can really shine and set yourself apart. Again, same thing by identifying local health systems and hospital alliances, just so you have a good idea of who are the sources that could potentially be friendly and amenable to you approaching them for building bridges. As we also talked about, it's important to identify who are the market leaders in your geography. So are you going into an area, or are you currently practicing in an area where there is another academic center that is quote unquote the place for DBS, and you're looking to sort of identify yourself in a unique way, in a niche way, or is there none? Is it just a bunch of different centers who do it the same way and have done it, and you're just showing up or have been there and you're looking to distinguish yourself? These are different strategies that are needed. So identify those early on. Next slide, please. All right, identifying referral sources. This was one of the lessons I had to learn when I first started. And I didn't even know where to start, because there's no clinic during residency that tells you how to go find patients. So again, if you're looking at a hospital setting, particularly an academic setting, start from inside out. So find out who is the movement disorder neurologist or neurologists within your hospital, and they should be your first knocks on the door. Subsequent to that, you should also consider identifying primary care physicians and general neurologists in your hospital, because I was very surprised to find that how many general practitioners have large groups of movement disorder patients. And they just, for whatever reason, develop a niche in this group. They develop whatever amount of expertise that they have, and patients stay with them for years. So don't overlook that. Subsequent to that, you definitely want to approach the community neurologists as well as the primary care physicians. They're hard to identify. How do you know which neurologists in your catchment area take care of Parkinson's disease patients? And there are ways to do that. There are market data available, especially the vendors and providers of DBS hardware. They also have huge marketing departments that do have this information about who are the neurologists that prescribe the most frequently medications for movement disorder patients, and you can target them that way. And make sure that you make a list and rank them in terms of who are the most possible highest likely referral sources to the lowest. And then lastly, which is often overlooked, going directly to the patients is a very, very powerful tool, especially nowadays with social media. Patients are very well informed. They are very particular about their DBS care in this world. And so targeting them directly, it will never set you wrong, especially in the movement disorders world, where many patients talk to each other, they're online, they're support groups. And so you want to approach them. You want to find out where they gather. You want to give presentations. You want to give many, many presentations to support group. Local hospitals give grand rounds, go to foundations, go to symposia, give presentations to a support group, even if there are only 3 patients there. I have done it. It is painful, but you have to do it. And then once you're done, do it again. I learned this lesson from a non-DBS surgeon, a very famous neurosurgeon named Mitch Berger in San Francisco has this, and he says he's still to this day, he's proud of the fact that he goes all the way out across the bay and gives talk to tumor support groups, and there are only 2 of them. One of them is blind, and he still gives the talk. So this is something that is just difficult to do, but you have to do it to maintain your presence out in the community. And then increasingly important is to have a website and social media presence, because patients look for it. And so you want to make sure you're presented and represented very well out there. Next slide, please. All right. To me, this is probably the most important message. It's how do you solidify your referral? So you found a neurologist, made a phone call, or met them. So how do you get from there to having them like you and send you patients regularly? So you're not doing this for 10 years of constantly giving talks, shaking hands, and so forth, even though you have to maintain it. At some point, you want them to like you enough to just continuously have a relationship with you. And so it's very important to at least have one face-to-face meeting. There is something to be said about 2 physicians sitting down, talking about their philosophies, and be a humble monk. Yes, we are DBS trained. We've gone through many years of training, rough training, but at the end of the day, these referring physicians, they see you as someone who's borrowing their patients. So I learned very early on that the magic trick here was to be a completely humble monk and be subservient to them by way of asking to borrow their patients, rather than going in from the ivory tower and saying, "Oh, you're lucky to send me a patient." Always send the patient back. So let's say you have established that relationship, you get a patient from a referral source and you implant them, the patient hopefully does well, which I'm sure it will. You want to send the patient back to them, even if it's just for medication adjustments, so that the referring physician has the choice of continuing to care for the patient in their capacity, or tell you, no, you can program them and you can keep them. So you're keeping the power in the hands of the referring physician. That goes a very long way. If you're in a center that is building a practice and things are happening, you're doing research, send quarterly, semi, or annual newsletters to all your referring physicians. Let them know what's new. Let them know what you've done, what you've accomplished. Did you get a grant? Did you get promoted? Did one of your patients have a good thing to say about you? Put it together into a newsletter. They love that. It just shows them that you're in touch with them and you're keeping them informed. Promote yourself. Do you have a niche? Win-win alliance. One of the things that worked for me very early on when I went out into the community, I noted that some of these referring physicians were more than happy to send me a patient, but they were very anxious about who's going to program them, and they had no idea how to program, but they wanted to learn. And at that time, it was within my resources to have our programmer actually drive out to these new referral sources and help program 1, 2, or 3 sessions with them. And we would realize that they either love it, they go to take courses and become a program or hire a programmer themselves, or they say, no, that's not for me. You can continue to program them and I'll do the medication management. But that is what set me apart from all the other DBS surgeons by way of I was the one who would send the programmer out. So find out how you can be unique. If you're in an area where there are multiple DBS surgeons, what sets you apart besides your smile and outstanding skills? Then lastly, maintain communication. Every time you see a patient, you send the referring physician a letter. When you operate, I used to call from the OR and say, hi, I operate on your patient, they did well. I don't do it anymore, but I do send a follow-up letter after surgery. And if you're doing a new technique, if you're bringing a robot in or whatever is sexy or nice, send them a note. Share with them that you've upgraded to this or you're doing something new, so they can kind of see that you're staying up to date, doing the latest and the greatest. Next slide, please. Okay, marketing resources. So how do you find all this information about where these people are and how do you give them stuff, basically? Locally, if you're partnering with a hospital, and this is also available for purchase if you're a completely private practice, you need to get the ICD code. So basically, if you're in a center, academic or private hospital, there are patients who visit that center and that get diagnosed with movement disorders. So there is a database of these ICD codes that you can get, and then you can send mailers out or send letters out about talks that you're giving, so that they know you're on the radar and you can sort of help them come out and listen to you talk if possible. Reach out to your marketing departments to see if there are any dollars for symposia. If you're in training and looking to get a job in the DBS world and have to start or grow a practice, it's imperative that you discuss ahead of time funding for marketing your practice, because if you're starting and you're looking to grow, this is going to become very handy. And also help them with setting up talks. Every hospital has an individual or a department that can help you. They'll call other hospitals in the area, set up grand round talks for you, where you can go and give talks to a whole bunch of referring physicians or physicians at the same time. They help you set up educational events, and they can help you set up your social media. Get the prescriber information, as we talked about. Companies are very good at this, and they can get you this information. That is your gateway to knowing who are the big players in town. Your institution can help you with social media customization, so that when patients search for specific terms, your information comes up, especially if you're local to them. And then pair in with the foundations, Essential Tremor Foundation, Dystonia Foundation, Parkinson's, and make sure you're on the radar, so when they have symposia, they can tap you to go give a talk. And lastly, on your website, make sure if you have a website, it's a good website. So it's, you've trained hard, you've accomplishments, put them up. Make sure they know your pedigree. That sets you apart. Discuss your research interests so that, patients know that you're actively involved and you're creating new knowledge and you're contributing. I'll talk about all the services that you offer. Next slide, please. All right. So the classic pearls are extremely true, in my opinion, in building a DBS practice. Be available. So if you're setting up a DBS practice or if you're growing it, make sure if a patient is trying to get a hold of you, or if a referring physician wants to send you a patient, they can find you. Many academic departments and many hospitals, clinics, departments now have all these triages, and someone calls and you have to push 10 buttons to get to someone. That can be daunting and problematic. So somehow find a way, at least early on, for a patient to call a number and get someone live on the phone, and make sure that your team members are fully trained, so that the person who answers the phone, to the nurse, the advanced provider, and all supporting team members all know what are the components of a DBS program. So when someone calls, everyone is educated on how to respond and talk to that patient and help them set up a visit. Next, be affable. We talked about this. When you are dealing with referral sources, be as humble as you can be and be as thankful as you can be. Yes, when we go to meetings, you can be the big giant person that everyone bows to and you can give the big podium talks. but this is the community. You're wearing a completely different hat. And many times you have to go to these practices and sit in the waiting room next to patients until the doctor is ready to see you for a visit. I've had to wrap my head around it, but it's the way of the world, and it goes a long way if you stick with it. Build bridges. If someone is mean to you, it's very easy to think, well, they're just below me anyway. Find a way to find what you have in common and make it work. And then be able, obviously, this is, without saying, you're all extremely well trained. So make sure you select the right patients, which is one of the things that's very important early on. You don't want to get into complications because you're operating on very complicated patients. And then make a database before you do your first case and keep it up, because you'll never have time to do it later because you're just going to get busier. But that will help you keep track of your outcomes and your patients. And that is good information to advertise about yourself that, that many other DBS surgeons don't have the time to do. Next slide. Thank you.
Thanks so much, Dr. Sani. Are there any questions?
I see a raised hand.
Is that Adolfo saying yay?
It's a clap.
I'm assuming,
it's a
yes.
clap.
A clap.
Clap, okay.
Yeah, great. I'm trying to learn more about Zoom and use this reaction. Today I had a meeting, and for the first time I used the live polls, and it actually worked really well. It's actually, I didn't have to do anything outside Zoom, so it worked well.
All right.
So now we're going to see me try to do this and try to share. So now, Adolfo, since you're the expert, how do I share with Alone?
Well, should I go ahead and I'll share my screen now?
Yeah, can you?
Yeah, let me go ahead and do
Yeah,
that.
so you...
Host disabled attendee screen sharing. Okay.
Right, so the Zoom late, I think this week, they upgraded the security because people were like,
Zoom
just showing up.
Zoom
right, so now, yeah, so probably the easiest, Julie, is if you stop sharing and then just, great, and you allow Dr. Mogilner to be a co-host, then he should be able to share. Or try it now and try it.
Can you try now, Alone?
Yeah, try now first.
It still says disabled.
Right, so you either have to.
I got it.
You need to make him a co-host.
Yeah.
Okay, how'd that go?
There we go. Got it. Okay.
Awesome. There was a neurosurgeon light bulb joke in there, I think.
No, that was
So many thanks to Dr. Alon McGillner for giving this talk. We're going to switch gears a little bit here. And, this was supposed to be kind of the Pearls talk or Pearls session. So Dr. Sani was talking about Pearls of building a practice. And now Dr. McGillner is going to talk about the Pearls of doing SCS. And, for all of you, when I still have a tough case, I call Alon. So I'm looking forward to hearing what he has to say.
Well, thank you very much, and thank you all for attending. So again, a little alliterative title, Percs, Paddles, Pearls, Pitfalls, some disclosures. And again, I would assume that most of you are aware of the differences between the two of them. And really, I want to go over things that I've learned over the years in terms of why we use one or the other. And what I say now is not what I would have said 5 years ago or 10 years ago or even 15 years ago. And there is some science to confirm one way or the other, but really it's a matter of my own sort of feelings based on whatever science we have. And we'll talk about the literature, the complications and outcomes we have. So I have a few case presentations at the end to show our choices and the reasons to use one or the other. So again, as you're aware, there are differences, the fundamental differences between the percutaneous and paddle leads, the thin percutaneous leads, which are cylindrical. They are not insulated, so current goes 360 degrees. They can be placed via epidural needles. They can be placed by non-surgeons. The paddle they are wider rectangular leads. They are insulated. They need to be placed surgically via a laminotomy. They are insulated, as I mentioned. Now, what am I not talking about today? Those root ganglion leads, because they are only percutaneous at this point in time. They have been talking for at least 3 or 4 years to develop a DRG paddle, but that will be something for a different time. At this point in time, they are only percutaneous. So, as I mentioned. Now, in terms of the trial, so What do we do for spinal cord stimulator trials? I would say as a rule, they should be done percutaneously unless the epidural space cannot be accessed via needle. So as a PAR decompression fusion. And those of you who have done a lot of them, of course, we're all familiar with referrals from pain management doctors. We will get a difficult trial every so often from a pain doctor who couldn't access the epidural space and will ask us to do, so to speak, an open trial. But that is rather rare. And unless you really can find a reason to do it via laminotomy, laminectomy, you should do it percutaneously. I will say if you're in the community, you may find, which I have found, some orthopedic surgeons who actually will do all their trials open, which I think is actually wrong. I would not say malpractice, but they were never trained percutaneously. So you will see scenarios and cases where people will do paddle trials. I'm against that for a lot of reasons. It's riskier, it's more painful, so to speak. And I think psychologically, you are committing a patient to the bigger operation. I think it's difficult to have equipoise with a laminectomy trial. In other words, once you've done the lion's share, the patient may say, let's just implant it, the hard work has been done. So again, percutaneous trials always, unless you cannot do them. Epidural space should always be accessed below the levels of the contact location. So for a standard thoracic placement at the T8, 9, 10 level, you should go around L2, L3. I will show some cases of cervical that I will also, there are some pain management doctors who will start lower down and thread them all the way up because quite frankly, they're a little bit uncomfortable doing an epidural stick in the higher thoracic region. For a cervical, I will do a T1-2 or a T2-3 stick. It's just easier to direct the lead a shorter distance. This is just an example of that. Again, without going into many of the details, this is an example of a bilateral percutaneous trial. I have marked out the generator. This would be a percutaneous permanent implant. The angles here are a little bit more than 45 degrees. You do like to have the angles as shallow as possible. That was the best I could do in this patient. And the reason is that that will allow hopefully for the easiest and most facile passing of the leads in a cephalad fashion. And if you are placing two parallel symmetric leads, a number of ways to do it. Again, I usually do at the same level, one side on the left, one side on the right. There's nothing particularly wrong about doing them one level below the other. And this is my setup. Actually, we have a newer OR, which is fancier. This is our older OR. So again, the patient is prone. I use the C-arm, obviously. And there you see a screening. During the screening, the patient is under sedation. The leads are connected to the temporary screener, and I would assume you're all familiar with the screening process where the patient is asked for paresthesia-producing trials. Of course, if you're performing a trial of a system that does not generate paresthesias, you really do not have to actually do this. That can save time from a trial. And that, again, in terms of which manufacturer to use, I would not. And which device to use, I will not go into that during this talk because that could be another 10 other talks. But again, if you do not ask the patient, the connection really is only done for one reason, and that would be to check impedance in the rare instance that the lead you have is bad. So if you are not testing the patient on the table, most people will just connect them and check impedance, and then if it's okay, finish. Now, in terms of complications of the percutaneous, from the procedure itself, as you get better at it, you'll hopefully have fewer and fewer of these, but it happens every so often to even people who've been doing this for a while. Let's say, one of the most frustrating complications is a CSF leak. It is a large needle, it's a 14-gauge needle, so it's unlike, let's say, a usual LP in that there will be a relatively high chance of spinal headache. And that can completely confuse the answers of the trial. So in other words, a patient may not be able to assess pain relief given the severe headache. So what do you do if you get a wet tap during the trial? There's no correct answer. No one will fault you from aborting the procedure. That is a good answer. So again, no one will fault you for that. Just stopping and saying, listen, we're done. I'm unclear if the trial will work. If you do wish to go ahead, you can attempt one level higher and hope that the patient will not have a headache. And then you can discuss this again, controversial, giving an epidural blood patch. So if you ask the anesthesiologists, they will tell you that an acute blood patch is usually ineffective. However, I have done them and I will do them at the time of a trial if I want to keep the lead in, whether or not the data suggests that. So again, there's not necessarily data to prove that. But if I want to proceed with the trial, I will go ahead and after I'm done under fluoro, do a blood patch at the level where the leak was obtained. And how do you avoid it? Again, sometimes it's unavoidable. You can imagine that if you're more oblique, it should prevent you from penetrating the dura. But as I said, every so often, so unfortunately, even having done this over and over again, this can happen. And over time, you will, there are thoughts that there are particular patient populations, younger female will have more of a probability of a spinal headache where an older person wouldn't. And maybe in those cases, you would want to proceed or not. But I would say no one will fault you from aborting, waiting till the headache resolves, and then proceeding at a later date. This is one work that I did based on my real world experience where we had a patient who needed an epidural blood patch on the table. The anesthesiologists were unable to draw blood because she had bad venous access. So I asked for some Tisseal and was able to inject it. The good thing about the Tisseal is that 4 cc's of it, the smaller amount, will expand to the almost double to triple the size. So if you're in an OR, particularly a neurosurgical OR, and this occurs, this is my treatment of choice, using epidural fibrin glue, Tisseal, at the end for the blood patch. What other type of complications you can get? Anyone who's done enough of them has had cases like this as well, where you go ahead and as you're either placing the needle or passing the lead, the patient may jump or the leg may move, and they can then, if you're unlucky, so to speak, be left with new, severe, and almost intractable neuropathic pain in that extremity related to actual irritation of the nerve root and or the spinal cord at the level. Sometimes, again, this is another thing that can completely ruin a trial, in that you're trying to treat a chronic pain syndrome and you create a new acute pain syndrome. Again, I have, without trying to, I cannot pin it down, but it may again be due to your angle of approach. It may be due to stenosis and so on. But if you do see someone jumping on the table with a leg, you be prepared for that. There's very little you can do for that. You can give some steroids, but usually the pain is so severe that nothing works, and just except for the tincture of time. I have never seen it permanent. It will always get better in my experience, but as I said, it can ruin a trial. So if that does happen in my experience, if I was trialing one lower extremity and I, so to speak, ding the nerve root there, you send the patient home if the lead is already in, but be aware that you may not be able to assess the trial appropriately. I will give them steroids temporarily and see if it gets better and just hope. But as I said, the longest time I have seen this last was with the dorsal root ganglion at the S1 level, but I have not seen it last more than a week and fellow panelists can chime in at the end, a week to 2, and it usually gets better in that time. So again, another potential complication from the percutaneous placement. Next slide. Okay, so now in terms of moving on from the laminectomies, we'll discuss as well in terms of complications, but the big question is the choice. You are a neurosurgeon, you're trained in functional neurosurgery. You can do percutaneous, you can do paddle. What do you want to do for this patient? Now, in your referral pattern, and this could go back to ASSFN's talk, sometimes as a surgeon, you have referring doctors who want you to do something, and sometimes so for example, they will say, I want you to do the paddle. And in those cases, unless there's a reason not to, that's reasonable. I determine on a patient-by-patient basis, there are advantages to percutaneous, which are less incisional pain, same-day discharge pretty much in all cases. The disadvantages, there's a higher risk of lead migration, less efficient energy use. For a paddle, what are the advantages? It does not migrate. I've seen one in my career of someone who was hit literally 2 weeks out was with an older, smaller paddle lead, a 4x4 specified Medtronic, was hit by a car, flew up in the air, and the lead migrated laterally. So again, you can safely say these leads should not migrate, and they deliver energy more efficiently, which means that if you're using a primary cell, you need less energy, and so on. Disadvantages: the procedure is more painful. If you do have spinal stenosis, that can be very risky. We'll discuss that in a minute. And again, so now in terms of the paddles, going on to that leads into the issues of paddle placement. At this point in time, there are probably few people left who do them awake. Most people have moved to doing them asleep with intraoperative monitoring. There are now many publications that talk about it. The last time I did an awake paddle placement was about 15 years ago. I think there's no reason to do it nowadays. And again, there are a number of papers that discuss how to use standard monitoring that is provided to determine appropriate placement. Remember that these patients have already had a trial. You know the level already. So really what you're looking for is symmetry, laterality, left and right. So I will do all of them under general anesthesia with EMG monitoring. And again, this paper really shows, this is a great study led by Steve Fulowski, where they did as best as you could this first paper was a retrospective review showing better outcomes with general anesthesia. And then they had another paper where they actually randomized patients and the outcomes are all better for sleep. So to go over it again, 2 reasons to do it. Obviously the monitoring is used to protect the cord, but also to confirm appropriate location. So what are the pitfalls? And I'll just give you an example of this. This is a patient referred to me who had a paddle lead placed by another surgeon, but developed acute left-sided chest wall pain. They ruled him out for every type of cardiac, thoracic, and GI issues, and it worsened with extension. And he comes to me 3 months post-op. And if you look closely at the x-ray, you do see the lead is a little bit off center. It's not the worst, but you can see that the anatomic midline is here and the lead is off to the left. And if you look at the CT, you can actually see it more clearly. So what is going on here? It's actually compressing the thoracic nerve roots on that side, an eccentric lead, and that is something that can happen with paddle leads. And there have been papers about that. We wrote up a series a while back, patients who presented post-operatively after a paddle lead with thoracic pain, and we had to reoperate on a number of them and decompress the cord. So that has to be, again, looked into. In a variety of the patients, in a small number of patients, if the pain is not severe, it can get better. It may just be due to dissection and manipulation. But if the pain is unremitting, a decompression, either removal of the lead, of course, or a further decompression is the best way to treat symptoms. Now, that leads into another thing. Before placing a paddle, you should have cross-sectional imaging of the spinal cord with an MRI or a CT myelo, period. That is now what we call standard of care. Now, I just wanted to show this movie here. This is where issues can occur with paddle leads. So this is someone, and not me, another person trying to place a paddle lead it goes off to the right, it goes off to the left, it goes off to the right, it goes off to the left. And ultimately it's placed eccentrically off to one side. The reason I have these films actually is it's a medical legal case because they used monitoring. The monitoring was appropriate, but the patient was not happy with the pain relief. There are times where the lead can just not be placed in the midline. Why is it occurring? If you MR'd the patient and it looked fine, sometimes we just don't know. Sometimes the anatomy, scoliosis, some epidural scar tissue is there, but spend the extra time to go ahead and make sure that the lead is placed more in the midline. And what you can do in that regard, what can you do? Obviously, first, don't try to shove the lead in, so to speak. You can do a complete decompression, just remove all the bone around it, which I have done over time, particularly in multiple revisions of scar tissue. That's the complete decompression. How do you anchor the lead? Well, one way is to place the paddles under the edges of the paddle under the bone. And I always place fibrin glue over the lead to glue it down. Another way to do it is partial decompression. So based on where the obstruction is or are, do you have to remove more bone? So this is an example of a 2-level laminotomy. So I had to perform laminotomies at 2 levels just to get the lead in. You see, this is another one where actually there's a 3-level laminotomy as well, a different lead. So again, if you're having trouble, the easiest thing to do can be, or the best thing to do, so to speak, there's one laminotomy, second arrow is the second one, and there's the third one. So in those patients, that's the appropriate thing to do if you do want to have the lead placed appropriately. What not to do? This is a patient referred for a paddle to another neurosurgeon. Percutaneous leads were done, and you can see where I'm going. There's a hard disc there, T8 at T8-9, and you can see on the MRI, again, the important thing to note, not only is there cord compression, but it's hard, it's an osteophyte. Unfortunately, the patient had this done, ended up paraplegic, because you can see the T2 signal in the cord. So in terms, this is a classic paper which really talks about safety of paddle leads. We consider a canal stenotic if CSF is not visible anterior and posterior to the cord. In addition, exactly, so that is rule number 1. If there is a question of stenosis, think very carefully about a paddle electrode. And if you are proceeding with a paddle electrode, consider doing a decompression up front. And they talk about the angles of approach, of course, so the way you're placing the paddle lead is to minimize the downward pressure on the spinal cord can hopefully also minimize the number or possibility of a neurologic complication. In terms of cervical, I have moved away from paddle placements, except when you cannot do it percutaneously. I have found, I think there are multiple issues with that. Patients develop cervical stenosis over time. So if someone has had 2 percutaneous migrations, I would consider it. Otherwise, I always place percutaneous cervical leads, even knowing that the stimulation can be positional. This is just an example of a French report where the patient developed stenosis over time. So 5 and 16 years later, patients developed stenosis. This is a patient who unfortunately was referred to me after a percutaneous trial, referred to permanent implant. And again, you know what's happening. They woke up with severe pain and weakness on one side, came to me with the lead in place. And after, if you look here, there is cord compression there. Not that bad. You wouldn't necessarily do an ACDF, but woke up with pain and weakness, was told it's just an exacerbation of your CRPS. Go home, don't worry about it. Your strength recovers, but left with pain, and you see signal change in the cord after I removed the lead. This is a young, thin person. You wouldn't imagine that there would be issues, but again, this is a really minefield, and you have to be very careful of this, particularly cervical paddles. Some people will, to prevent that, will place C12 electrodes, so there's a lot more room there. So this is a person, just to give you an example, who had brachial plexus injury, a patient of mine who could not have a percutaneous trial even done because there's stenosis over here. So we just went ahead and I went straight to the permanent and implanted bilateral or dual C12 paddles, and the patient did well. This is another case who had a percutaneous trial by another physician and then went on to have a C12 placement, right, after a lead migration. And they said, okay, we'll do the C12 placement. And what happened, unfortunately, the patient also woke up with new pain in one of the arms. That's had a fairly large, a wide paddle, and woke up with severe pain and spasms, again told it's an exacerbation of the condition and sent home. The pain physician ran this by me, could not get an MRI. We did a myelo-CT. Hopefully I'm not running over. The lead looks okay, but I took the lead out, and interestingly at the C2 level had an injury. So the C12 level, which is safer, let's say, than the subaxial spine, is not 100% safe either. And when you look at this patient and you look at the previous patient, you understand why. You see there's a tremendous amount of CSF here, but not much here. So again, the C12 is a possible reasonable way to do it, but don't think that you are safe at that level either. So to summarize, percutaneous trials should be performed in all patients unless they cannot be done technically. In terms of permanent, my way is I always do percutaneous. Thoracic, assess the canal diameter, assess different factors of the patient, the age, the body habitus, the activity level, comorbidities, and make your decisions as long as you know and explain the risks and benefits. Cross-sectional imaging, of course, is important. And that's basically it. Thank you. And I will unshare my screen at this point. Okay. Okay, you're back?
Yes. So thank you very much. And just in the interest of time, we'll keep going, but we have the chat function. If anybody has any questions for Dr. McGillner as we go, I'm sure he'd love to respond. And now, as I mentioned, you're meeting all my friends and learning all my secrets. For a long time, I thought I could just do no wrong with lead placement, and then Adolfo moved, and I realized it was really Adolfo doing a wonderful job with my programming. So if you ever have a problem with programming, he's your guy. And you know, he also has worked really hard to streamline microelectrode recording. And so for all of us, I think these are good tips to learn in the OR that we can bring to our neurology team as well. Dr. Ramirez.
Thank you, Julie. Thank you. Thank you. I do miss being in Albany. So thank you for the invitation, first of all. And I thought that maybe for this next 15 minutes, I was just going to try to do some high yield pearls of the use of MER, and we can move to the next slide if you don't mind. And I incorporated a variety of things. It's not all about MER, because I'm sure that a lot of people in the audience have seen like the classic descriptions of, okay, these are how the striatum cells sound, and this is how they look. And this is how the GPI cells look, and the GPE. I wanted to do something a little bit different, and then just talked about more of the process and what are like the things that actually have a big impact when you're doing MER, if you are doing MER for your DBS cases. As there's now a lot of options. You can do it asleep, you can do it with imaging. However, there continues to be important information that can be provided when you do physiology, as sometimes you would be surprised because some leads are perfectly placed based on based on imaging, but the patient's not getting the benefit that you want. And conversely, sometimes you have patients that are doing really well, and you look at the postoperative imaging and they look a little bit off. So I think that in certain situations, the MER could be quite helpful. And one of the things that the way I divided this really quick talk is in different steps. And I think that one of the most important steps is that when you start partnering with a neurologist or a physiologist, the main thing that you want is to be consistent. And I don't need to say that to functional neurosurgeons. Every single functional neurosurgeon I know are almost obsessive compulsive, right on the border, and like consistency. And that's how you do it right. You do things the same way, you are methodic, and you're repetitive. So you really want to be consistent when it comes to doing MER. Next. Then you definitely want to plan your surgery with your surgeon. It is really valuable information, not only to try to get the target to the best place you can, but also to take that information back to the clinic as if you're going to do any programming. So you can talk about the indirect targeting, the coordinate systems. You can also refine that initial targeting using direct targeting, looking at the images. And then you start talking about the angle. And I think that sometimes we don't think enough about how that approach angle really is going to change the way that you're going to place that lead. So MER is important, and it's particularly important when you are moving away from the traditional approach angles, and the stereotactic target may not be as important as the final position of the lead within the volume of the tissue that you're trying to stimulate. So you want to be mindful about that, and you need to discuss that with your surgeon. Next. So to be successful, if you're going to do MER, you need to be able to eliminate the noise from the signal. And this is actually, it sounds very simple, but sometimes it's not. So first of all, you have to be able to educate the staff. You have to tell people to whisper, especially during the parts of the procedure where you really need to listen. So not uncommonly, you know, there's a lot of noise, there's cell phones, you want to turn off the lights, you want to use headphones if you can. You want to make sure that your system, it's also has a good quality. It's a good sound quality. That's really, really important. And you want to check the wires for integrity. So you want to make sure that the ground, the device, and all the connections are fine. And you want to have some backup as well. You want to have some extra cables, because the last thing you want to have to deal with is to discover that one of your cables is not working. The patient already has a stereotactic frame, is ready to go, and you don't have that connection. So you want to have always some backup. Keep a list of technical noise problems and always run the list. Goes back to my initial point. You want to be consistent and systematic. So have a list and run it, and you can actually put troubleshooting to each one of those difficult technical difficulties that you may face. Next one. Sorry, this should be step 4, but the next step is know what to expect. Actually, MER, when you're doing MER, it's important to identify the specific signals of those cells. You wanna know how they sound, you wanna know how they look, but more importantly, you wanna know when are you gonna see those cells. You wanna identify the borders. And if I try to make MER simple, as the title suggested, it's more important to be able to recognize the presence or the absence of those cells, so you can determine the three-dimensional border of the structure that you're trying to map. So for you to be able to do that and predict what's coming next, you need to know what to expect. And you also wanna base that on your imaging. You wanna talk to your surgeon about that. And you also wanna check with your surgeon if something doesn't seem right, or if everything is going as planned. You also want to always run it by the surgeon and verify that what you're seeing is expected at the right depth. I can tell you a few times we were seeing really unusual signals and we were supposed to be at the target, and the drive was not moving the microelectrode recording, and we were like, I don't know, 10 millimeters above the target. So always check for that. Next. And when you do MER, there are different ways to do it. You can create a map of a single tract and then make expert decisions on future tracks. So in other words, you plan with your surgeon, you determine the trajectory that's going to be the most useful, the trajectory that's going to give you the most information for the implantation of the lead. And based on that information, then you adjust, and you can decide to do 1 or 2 tracks more, depending on the target, depending on your experience, and depending on what you see. You can also do the Bingham approach, where you actually do simultaneous stimulations, 2 or 3 tracks. I think most centers use 3 these days. Or the other option is that you can do a single pass and then verify the location and look for specific signals that can tell you that make you comfortable enough that you can implant the lead. And obviously, MER is complemented by macro stimulation and the use of stimulation before you leave the operating room, and so on. Next. So this is a pretty simple example of the signals that you would encounter in a traditional implantation in the GPI. So you can see that you will find some signals in the stratum, then the GPE, then there's these cholinergic cells in the border between the GPE and the GPI that have pretty unique firing pattern. But then you get to the GPI, and in Parkinson's disease, the difference between the bursting, the frequency, the number of cells that you will encounter are much, much higher. The frequency, it's almost impossible to find single units. They're firing all at the same time. So as you can see, if you can identify that pattern and it makes sense based on the anticipated trajectory, that information is quite useful, even if you don't know how to separate a bursting cell versus a pulsar cell or a cholinergic cell in between them. But you can clearly map when the signal, the action potential of those cells start and where do they end, which then will create a picture of the borders of the structure that you're mapping. Next. I think next one.
Yeah.
Thank you. So really, really quick tips when you are trying to do microelectrode imaging in the pallidum. And the GPI is interesting because of anatomical differences, size, and location of the structure among patients. Indirect targeting may not be as precise. And as I mentioned before, always look for background changes. So that's the first indication that you're actually moving from one area to the next one. And learn how to separate the cells from just white matter fibers. That is really useful, and it really guides you to know where you are within the target. You want to find the posterior border of the target. You also want to know where the medial border is, because in these cases, you want to be close enough, but not too close that you would induce side effects at low thresholds that will prevent the adequate outcomes of these patients. We will limit it by the occurrence of side effects. The stone is a little bit different because there's a lot of similarities between the GPI and GPE, and sometimes it's a little bit hard to find that transition. They're maybe a little bit slower. Okay, next. Similarly, for STN recordings, there are a variety of different signals that you will find during your pass. Typically, depending on your approach, you can get a little bit of the thalamus. You can identify some cells that some people argue that maybe you can identify cells in the zona incerta. But then the key when you're doing STN is that it's so easy to see those cells and listen to those cells because there are so many of them, and they're high frequency, high amplitude, they're really bursty, they do it in groups, so they're very easy to identify. And then the information that you can get from the length of the run of the STN, the characteristics of when in your trajectory you find the STN can help you to decide if you need to do another pass or if you may be satisfied if you're doing a single pass track for implantation. So knowing what to expect and when to expect those signal changes is as important, or probably more important, than being able to quickly identify the unique firing characteristics of the different neurons within the target. The substantial nigra sometimes is much regular, and it can be also useful for localization. It doesn't extend as laterally as the STN. It tells you that you're a little bit deeper, etc. Next. So in these targets, you could also use intraoperative testing and take advantage of some of the characteristics of these cells within the somatosensory region of the target that can actually also give you important information, letting you know that you're in the area of interest. So this is an example on the left of, if you can, I hope you can run the video, Julie. It's an example of, it will work much better with sound. I don't know if you can hear the signal, but this is a kinesthetic cell so you can see changes on the action potential, and you can actually hear synchronous changes when you move the joints in this patient. I don't think you can hear it very clearly. You can run the other one, Julie, if you want. This is also an example of a tremor cell, which have very unique rhythmic characteristics that may allow you to also provide important localizing information within the target, specifically in the somatosensory region of the target. So next. So some quick tips for mapping of the subthalamic nucleus. Remember that the medial border of the STM and posterior border can give you sensory side effects. The capsule surrounds anteriorly and laterally the STN, and you can identify that border with microstimulation if you're close enough, as you can induce muscle spasms contralaterally. There's a gap between the STN and the SNR, and if you have a big absence of SNR, as I mentioned before, it may suggest that your lead is your trajectory is a little too lateral. And when the STN when you identify the STN a little bit higher than expected, or if there's a large gap between the STN and the SNR suggests a more anterior location based on your trajectory angles. Next. And finally, just a few words about the thalamus and how to target the thalamus. The targeting of the thalamus is slightly different. Most surgeons would actually try to find the sensory component, the sensory nucleus of the thalamus, the VC, as you know that if you can identify precisely where the VC starts, you can implant the lead 2 to 4 millimeters in front of it, and that will be within the VIM. And there are many different techniques these days. I think that everyone is refining their technique to try to determine the right angle to place the lead within the VIM, the depth, as some there's incidental stimulation of the zona incerta, and this is an example of actually by dual leads. So you can also stimulate in the VOP as well. Next. For thalamic surgery, the use of microstimulation during thalamic surgery, where we're trying to find the border of the VC, is incredibly helpful. It really doesn't take much to induce paresthesias in those patients. Just a sprinkle of electricity can actually give you powerful localizing information, as the somatotopy in the thalamus is so precise. So a mediolateral position will help you to determine where you are within the nucleus and allow you to place the lead based on that information. If you're too posterior, you're going to have sensory side effects, and you should consider moving your lead if during macro stimulation the sensory thresholds are less than 1 volt, maybe 2 volts. If you're too lateral, you're going to stimulate the internal capsule, and similarly, if you have low thresholds for capsular stimulation, you really want to reposition those leads, as that will limit the potential benefit in postoperative programming. And remember to try to use either macro stimulation and the somatotopy and recordings of depending on your approach, you can, in a more oblique approach with an angle of maybe 65 degrees anterior or so, in the slope, it may allow you to really map the different components within the VOP, the VIM, and then finally get into the VC. And if you go deep enough, you can actually see the base of the thalamus to help you to plan where you're going to place the lead. And I think that's it. Thank you so much.
Thanks so much, Adolfo. That was great. We knew we were going to go a little bit over today because we were trying to fit all 4 of us into the session. And what I'll do is I just have a little bit to add. So hopefully this will be about 5 minutes, 7 minutes, and then hopefully we have just a few minutes for questions. So just a little bit about streamlining DBS. For people that know me, one of my big motivators is efficiency. There's probably a lot of reasons for that. Sepper and I were talking about some of those before this started. Here are my disclosures. Some of these people make devices, but I'm not going to speak to anything particular about them. To kind of echo what Adolfo was saying, I truly believe that this is like an algorithm, and making sure that you do everything algorithmically and consistently. And so in terms of getting through MER reasonably quickly, we created these 10 steps to success. And again, we post all these presentations on the website that you have access to. So if you want to go back and refresh anything. Know those things that Adolfo was talking about in terms of the targeting, and just quick, easy tips that can help you do things. My talk seems to have a mind of its own today. And also know your patient. So make sure when you're getting in there, the patient is optimized. Use whatever version of an ERS protocol you have. How are you going to get the patient on anticoagulation safely through this? And make sure you bring a carbidopa, levodopa with the patient to the hospital in the original containers. I bring it to the OR with them. So as soon as they're awake, they can have some, or as soon as they're awake in recovery, because I think the longer they're on their, or they're off their Cinemet and their meds, the longer they're in the hospital. And I think this is really crucial because you know all the things that can happen in the recovery room while they're waiting to get the patient's meds, and the pharmacist doesn't think it's the right dose because the med dose is so crazy, and then they don't give you the meds. This is an easy way to make sure this happens. Know your guidelines. You know, these are NAC, the Neuromodulation Consensus Guidelines. And, you know, this has some recommendations. I often will send this recommendation to the cardiologists that are arguing with me about how people can't be off meds for a certain amount of time. Know what your parameters are so that your staff can answer those questions. ASSFN, which is a pain organization, they actually have an app for your phone that, you know, you can, that they update regularly about some of these recommendations. And, you know, again, it's different when you're sticking a lead in somebody than when you're replacing a battery. You know, how OCD you have to be about this. I always do my planning and reviewing in advance when possible. You know, I know that sometimes you're integrating the frame and you have to do that, but looking at the MRI beforehand. I don't know who Adolfo was talking about when he was talking about bordering on OCD, but here I wrote my favorite 100 steps. And so here are my 100 steps, and I give these to everybody in the OR to know them, and I highlight that for everybody's role in the OR. And I'll tell you, you know, what actually happens over time is, you know, you build a team, everybody knows what their role is, just very similar to a script in a play. And we do fine if one person is out. When two people are out, it gets a little bit dicey. But this gives everybody the basis of what's going to happen. Assemble the right team. Here are some of our team members. And this is an opportunity for all of you that are going into practice. People like to be involved in DBS, just show them the videos, and they like to have something to do with this. And this is a way to set up your own OR team, because you get to meet all these people and you say, oh, I really, really need this for DBS, because you really need to be OCD about it. And then you know what happens over time? You get these people for the rest of your cases. Frame placement protocol. Your frame can make or break you. You know, I don't like to move my frame in between sides, and by making sure that frame is dead on, especially in the Y coordinate. Like, everybody gets obsessed about making sure it's okay on the X coordinate. It doesn't really matter, because you can adjust that. Z, you can kind of adjust, you know, but you want to be less than 1 millimeter or so off from side to side if you don't want to move things. Y is tricky, so spend time making sure that those pins are right at the same level on the head. Consistent OR setup. Do the same thing every time. What works for the room, and make sure the nurses know it, and everybody's working on that at the same time. Efficient physiologic localization. You know, we use this mostly as a confirmatory test, and know exactly what you're doing. You know, if you have 10 kinesthetic cells, do you really need the 11th one? No, you probably just need to go down and find the border. Likewise, you know, with the bottom of the thalamus, you know, you're deciding whether to go in the track you're in, going 2 anterior, 4 anterior, see what VC looks like, and really nail down what you need to know. I'll always get a CT the same day as the OR, really on the way up from the recovery room to the floor. Gets it out of the way, the patient's happy, I'm happy, and God forbid there is an issue. And then I have this information before, and I can plan for revising the next day or managing the patient appropriately. And, you know, this is like what the OR and what life in the hospital feels like, right? The giant game of telephone. So make sure that communication is effective, and you go from there. So lots of moving parts in DBS. It's important to define and understand what everybody's doing. The patient is the center of the team, and be algorithmic. And, you know, for those of you that do have OCD like myself, this is a great outlet for it. I'm doing puzzles while I can't be in the OR doing DBS. Here is the team involved in the care of our patients. So with that, do we have any questions?
Are you doing 1,000-piece puzzles or 3,000-piece puzzles?
1,500.
Oh,
I haven't gotten any higher than that yet.
we've done like 5,000-piece, and we're about to do a 3,000-piece.
Oh my gosh. Okay. See, this is a positive outlet. I was joking because I've had a number of patients test cocaine positive and that I'm trying to get to the OR. I'm like, I do puzzles, they do coke.
Julie, just a question. You had in your diagram, you had a CT. Did you have do you use intraop CT? Because your diagram had a CT.
Yeah, my fellow is trying to we're trying to do that and incorporate that, and that was actually, he's in a junior faculty development program, and that was his project.
Got it. Okay.
Is that how in practice, how likely is for somebody that's starting a DBS practice to have access to that technology, to do intraoperative CTs? Is that easy? Is that hard? It has been tough for us to consistently have it.
I think it depends on where you are and what you're working with. And, so I think there's different ways you can do this at all different centers, and do what you're comfortable with and do what you're trained on, at least when you're starting out. I'm turning into a dinosaur with this next statement I'm going to make, but, I used to target a certain way. And then we actually had a trial where I was forced to start doing multiple microelectrodes, and I realized that my STN target was always a little bit too posterior, and that adjusted what I was doing. So there's that learning curve over that first couple of years of practice that's really important to make changes. So whatever you're doing, try to do it one way, get it good that way, and then move on to other.
I can just comment about the intro. You were asking about the intraop CT. So, we're lucky to have one. We've also sort of arranged it that we have particular OR days, so I don't overlap with the spine people and stuff, because it is a very expensive resource. So in terms of intraop CT, I've been using it now for 3 to 4 years, and I rarely have done one case in the past year without it, the old-fashioned way. So if you're starting out, depends on your institution, where you are, what the resources are. But if you find that the spine people have a device, have one, you may want to use it as well. It can make your life much easier. So, but it's, again, depending what hospital, what system, not always available, but there are ways to, again, in terms of cooperation, to work out scenarios where you don't have to fight about the device particularly.
I think, I also want to echo what Dr. Sani said. That was one of the mistakes I'd made when I started practicing. I didn't keep track of all the cases I did. I didn't keep track of all the Botox patients I injected. I really wish I did. So that was something that I started doing once I moved. And it was really useful, because then you can learn a lot from your mistakes. How have you changed your practice? And you can also use it to, when you're interviewing, when you're advertising, there's a lot of pros and of having that information available. And it's so true. Do it when you start, because then you get really busy. It becomes really, really hard to try to catch up.
Here's a question about MER system, FHC versus alpha omega. Is there a preference? Elaborate why. And Alone and Suffer are responding. Go ahead. You want to say it?
I've used alpha omega for a while. I think nothing's perfect per se. I think there are. I have what's called the Neuro Omega, which is the research device as well. The support has been very good. They've had a number of advancements now. I really haven't had many issues with it. Then again, I've heard people who have been happy with the FHC. I think it depends on so many factors, including your support as well. What the team is, who supports you. If you do have a neurophysiologist with you all the time, that's great. If you don't, you may want to have something a little bit more turnkey, and so on.
Suffer?
I think they're both fine. Originally during residency, we used to have the old Axon, which was the FHC, and which was like basically a gigantic piece of brick in the room. And then when I went to fellowship, we were transitioning from the FHC system to the Alpha Omega. That's when Fullstar made the transition. And so I kind of trained most of my fellowship time with the Alpha Omega. And I was in a program where Phil Starr did his own recording. So I was very hands-on with the machine. That's what I learned. That's what I was comfortable with. So when I became an attending, that's sort of the system we went with. So my advice is whatever you're exposed to and you're comfortable with, I think you'll be fine. They're both excellent clinically, and they are both companies are very receptive and excellent for research purposes as well.
Alon, you were saying that you were using the CT. Are you using the CT or the O-arm, and are you doing it all asleep?
So, okay, I use the arrow. I'm on call. I'm actually on call now, so quickly I will, I'm using the arrow CT. I do not do it all asleep. The ones that I do all asleep will be dystonia and Tourette's, and a very rare PD patient who demands having it done asleep. I offer it. In other words, there are patients. So, with good sedation, honestly, nowadays, even with the frame, with Precedex and so on, you can keep them awake for about 20 minutes. So I prefer to continue the old-fashioned awake and method. But so I would say, again, rare Parkinson's patients who are so anxious they want to be asleep. All of my Tourette's I've moved towards asleep. All of my pediatric dystonias as well, I've moved towards asleep. So for example, I'll do a bilateral, and I will record. So I still record. So I'll record. I'll get a scan with the first MER in place to make sure I'm happy with it, and then I'll get a scan after the other lead as well.
And then maybe a follow-up question: has anyone considered using Interrupt Arrow with BrainLab Elastic Merge?
We're trialing that now. I use an O-arm for our DBS cases that I've used for a number of years. We recently acquired the Arrow, not I, but some of the other surgeons in our department who thought it was the greatest thing since sliced bread, and it's not getting utilized as much as it should be. So I've been asked to trial it for our DBS cases as things go sometimes. And so I have done some dry runs with it. It seems impressive, not just the elastic merge, but also the tractography. Its user interface is nice. I haven't actually done a clinical case with it yet, so I can't comment further.
I apologize for the naivete. What exactly is the elastic merge? What's that?
So it's BrainLab's own repository of, I forgot how many, but it basically allows each individual patient's brain to be merged with a standard. It's sort of like when you brain into MNI space. It's a variation of that, and then that allows you to automatically visualize the tracks based on their standards. You can also upload your own tensor images and do the tractography based on your own.
Oh yes.
But it's sort of a standardization that they do.
I've been using, yes, so that's the Element software. Yes, I've been using that.
That's right. That's right.
So I've been using that. I've been using that now for all my cases. I play around with it. Their anatomical mapping is so-so, I would say, at this point. It's nice. It's easy to use. It's cool. The actual object segmentation, give it some time. It takes a while to do, and it's reasonable but not perfect.
Well, I think that's all the questions we have. And so I just want to thank all our presenters. This was a great session. I love it when I learn something, and it was great to see everybody. And thanks for all your time. Stay safe.
Thank you.
Bye-bye.
Thank you, everybody. Good to see you, Julie. Good.
Bye.
Bye, everybody. Good to meet you. Good to see you.
Bye.